Hello and welcome to the topic Interstitial Lung Disease in the Respiratory Medicine module. By the end of this topic, you should be able to define interstitial lung disease, discuss the causes and pathophysiology of this disease, outline the clinical features, list investigations which can help with the diagnosis of interstitial lung disease, and finally understand the principles of management of interstitial lung diseases. Let's get started. Interstitial lung disease, or also known as ILD in short, comprises a heterogeneous group of disorders that cause varying degrees of inflammation and fibrosis of the lung parenchyma, which is a space between the capillary endothelium and the alveolar epithelium. Its classification begins with unknown causes of the disease, which is termed idiopathic interstitial pneumonia, or IIP. Examples of conditions which are under this category are idiopathic pulmonary fibrosis, which is the commonest of all, non-specific interstitial pneumonia, cryptogenic organizing pneumonia, acute interstitial pneumonia, and smoking-related interstitial lung disease. Known causes of fibrosis are caused by systemic diseases such as connective tissue diseases like rheumatoid arthritis, systemic lupus erythematosus, systemic sclerosis, Sjogren's disease, and dermatomyositis or polymyositis. Other systemic diseases which can also cause fibrosis of the lungs are granulomatosis with polyangiitis, Jerk-Strauss disease, sarcoidosis, and hypersensitivity pneumonitis. It is currently believed that idiopathic pulmonary fibrosis is an epithelial fibroblastic disease in which unknown endogenous or environmental stimuli disrupt the homeostasis of alveolar epithelial cells, resulting in diffuse epithelial cell activation and aberrant epithelial cell repair. Activated alveolar epithelial cells release potent fibrogenic cytokines and growth factors, and it's these cytokines and growth factors which are involved in the migration and proliferation of fibroblasts and the transformation of fibroblasts into myofibroblasts. For normal wound healing to occur, wound myofibroblasts must undergo apoptosis. Failure of apoptosis leads to myofibroblast accumulation, exuberant extracellular matrix protein production, persistent tissue contraction, and finally a pathologic scar formation. And this is what transpires in idiopathic pulmonary fibrosis. Now, let's take a look at the common symptoms for this disease. One would complain of having persistent dry cough, fatigue, dyspnea, particularly during or after physical activity, digital clubbing, weight loss, and also complaints of lower limb swelling. Assessment of Velcro crackles on lung auscultation is a practical way to clinch the diagnosis of idiopathic pulmonary fibrosis. If bilateral fine crackles are present throughout the inspiratory time and are persisting after several deep breaths, and if remaining present on several occasions several weeks apart in a subject aged 60 years or above, this should raise the suspicion of idiopathic pulmonary fibrosis and lead to consideration of a HRCT scan of the chest, which is more sensitive than a chest X-ray. So it is important in the exam to be able to differentiate between conditions causing predominantly upper or lower zone fibrosis. It should be noted the more common causes such as idiopathic pulmonary fibrosis and drugs-related disease tend to affect the lower zones. Fibrosis affecting the upper zones include hypersensitivity pneumonitis, also known as extrinsic allergic alveolitis, coal workers pneumoconiosis or progressive massive fibrosis, silicosis, sarcoidosis, ankylosing spondylitis, histiocytosis, and tuberculosis. How about fibrosis affecting the lower zones? So as mentioned earlier, causes like idiopathic pulmonary fibrosis, drug-induced causes secondary to amiodarone, bleomycin or methotrexate, most connective tissue disorders except ankylosing spondylitis, and finally asbestosis. If we look at the spirometry pattern of the pulmonary function test done for patients with interstitial lung fibrosis or interstitial lung disease, typically you would expect to see a low DLCO. Most show a restrictive pattern of disease. Let's take a brief look at the common features of this condition. It is commonly diagnosed in the 5th or 6th decade, male more often more than females, frequently associated with smoking. There's a 3 to 5 year survival rate, which is 50%. It may be associated with acute exacerbations. Lung HRCT shows a pattern of usual interstitial pneumonia or UIP with subpleural reticular pattern with posterior basal predominance with more advanced fibrotic features such as honeycombing and traction bronchiectasis. Treatment would be physical therapy and supplemental oxygen, antifibrotic therapy such as pirfenidone, lung transplantation if the patient meets the criteria for it. As for hypersensitivity pneumonitis, it is also known as extrinsic allergic alveolitis. It is a condition caused by hypersensitivity-induced lung damage due to a variety of inhaled organic particles. It is thought to be largely caused by immune complex-mediated tissue damage or type 3 hypersensitivity, although delayed hypersensitivity type 4 is also thought to play a role in extrinsic allergic alveolitis, especially in the chronic phase. Examples would include bird fanciers lung caused by avian proteins, farmer's lung caused by spores of Saccharopolyspora rectivicula, malt worker's lung caused by Aspergillus cravats, mushroom worker's lung caused by thermophilic actinomyces. As for the presentation, in acute alveolitis, symptoms show 4 to 8 hours after exposure, and the symptoms include breathlessness, dry cough, and fever. There's also chronic presentation which occurs days later. As for the investigations, a chest X-ray would show upper and mid-zone fibrosis, bronchoalveolar lavage showing lymphocytosis, and there is no eosinophilia seen in the blood test. Next would be cryptogenic organizing pneumonia. This is commonly diagnosed in the 6th or 7th decade. It presents with pneumonia-like symptoms such as dyspnea, cough, fever, fatigue, hypoxemia, and restrictive pattern on pulmonary function testing. It may be idiopathic or secondary to polymyositis, medications, or malignancy. Lung HRCT shows migratory patchy subpleural consolidations with ground glass opacities, and the treatment here would include steroids and immunosuppressives. Silicosis is a fibrotic lung disease caused by inhalation of fine particles of crystalline silicon dioxide, or also known as silica. It is a risk factor for developing tuberculosis. Let's take a look at the examples of occupations which are at risk of silicosis: mining, slate works, foundries, and potteries. Features include fibrosis or fibrotic lung disease as shown by the arrow, an eggshell classification of the hilar lymph nodes as depicted by the circles. Lung biopsy establishes diagnosis, and this is performed via fiber optic bronchoscopy or surgery. Histology changes which can be seen include fibroblastic foci, honeycombing, and spatial heterogeneity. Chest X-ray may be helpful to suggest a type of interstitial lung disease. Peripheral reticular pattern in lower zones plus small cystic spaces suggest idiopathic pulmonary fibrosis. Central nodular pattern in mid to upper lung zones plus hilar lymph node enlargement suggests sarcoidosis. As for chest CT, that's the standard initial test. You may confirm the diagnosis of idiopathic pulmonary fibrosis in the right setting and obviate the need for lung biopsy. A chest CT also helps to better define disease extent and features such as honeycombing. It helps to exclude differential diagnoses such as malignancies, and it also helps to determine the best location for biopsy. When it comes to management, the lung scarring that occurs in interstitial lung disease can't be reversed, and treatment will not always be effective in stopping the ultimate progression of the disease. Some treatments may improve symptoms temporarily or slow the disease progress. Others may help to improve quality of life. Corticosteroids are among the medications that are extensively used in interstitial lung diseases and are initially treated which are initially treated with prednisolone, sometimes in combination with other drugs that suppress the immune system. Medications that slow the progression of idiopathic pulmonary fibrosis may also include pirfenidone and nintedanib. Medications that reduce stomach acid production or reduce the risk of gastroesophageal reflux disease include antihistamines as well as proton pump inhibitors. So oxygen therapy does not help stop the lung damage, but it can make breathing and exercise feel better or easier, prevent or lessen complications secondary to hypoxia, as well as reduce the progression of cor pulmonale. Next is pulmonary rehabilitation. The aim of pulmonary rehabilitation is not only to improve daily functioning, but also to help people with interstitial lung disease to live satisfying as well as a life with good quality. To that end, pulmonary rehabilitation programs focus on physical exercise, breathing techniques, emotional support, nutritional counseling, as well as encouraging smoking cessation. Lung transplant is an option for some people who have interstitial lung disease if they meet the criteria. And finally, when all treatment fails, the last option would be lung transplant. So talking a little bit about lung transplantation for idiopathic pulmonary fibrosis, it is considered due to the natural progression of the disease. Lung transplant may be an option of last resort, and for some people with severe interstitial lung disease who have not benefited from other forms of treatment options. Among other procedures that can be done in the workup or management of idiopathic pulmonary fibrosis include bronchoscopy, where absence of lymphocytosis in a bronchoalveolar lavage may be important for the diagnosis, and this procedure may be used to exclude any other alternative diagnosis. A surgical lung biopsy is best done via either an open lung biopsy method or video-assisted thoracoscopic surgery. It uses the sample to distinguish usual interstitial pneumonia from other idiopathic interstitial pneumonias. As for complications, they can be seen in patients with idiopathic pulmonary fibrosis, and these include pulmonary hypertension, cor pulmonale, as well as respiratory failure when there is severely low blood oxygen levels causing increased pressure within the pulmonary arteries and the right ventricle leading to heart failure. Now let's summarize. Interstitial lung disease is a group of lung diseases affecting the lung interstitium. It occurs when an injury to the lungs triggers an abnormal healing response. Interstitial lung disease may be classified according to causes, whether the causes are known or unknown. Idiopathic pulmonary fibrosis encompasses most of the interstitial lung diseases. A proper and detailed history looking for the occupational exposures and for signs of connective tissue diseases are the first and probably the most important part of the workup in patients with interstitial lung disease. Pulmonary function tests usually show a restrictive defect with decreased diffusion capacity or DLCO. Treatment-wise, pulmonary rehabilitation is useful. Antifibrotic agents are found to slow the decline of lung function. We have come to the end of this topic. Thank you.